Welcome back, guys. Another episode of the AltMed podcast. So delighted to have you back. And, for those who are getting something out of this and haven't yet hit subscribe on our YouTube channel, please do so. Give us a like on Facebook and all our socials. Mitch, any other comment you'd like to make before we dive in and introduce our guest?
I'm just stoked that you remembered it this week. That was fantastic. Well done.
Mate, I didn't have a like a little placard to hold up this week. I really that's next week. But
You've done us proud. Well done.
thank you. It is my genuine pleasure to introduce our guest today. One of the first doctors that we started speaking to when we got involved in this space. His profile since we first began chatting has hit meteoric heights. It is Dr. Matty Moore, based over in WA. Welcome to the show, Matty.
Boys, it's a pleasure. The pleasure's mine. The first time that we got on, video chat together, it was like, two of my best friends from home. It was fantastic. And look, I love seeing what you guys are doing. I love, how you're moving the space forward. And it's great to see and hear about the future of what you guys are doing. So the pleasure's mine.
Thank you very much, Matty. I mean, you were probably, I'm just trying to place this from a timeline perspective. Were you the very first specialist cannabis doctor in WA or thereabouts?
Honestly, I don't know. I probably not. I don't know really for a fact, but I know that in my area, I'm certainly the only guy that's really dedicating as much time to education and certainly getting more patients access to medicinal cannabis. So honestly, I don't know the answer to that question, but I think I was at the time, one of maybe 60 APs in the country.
Yeah.
And now I think it's about 200 maybe, if not that, almost.
Yeah. Well, we're going to just say that you were the first.
Okay.
It's a good line.
I'm the trendsetter.
And maybe before we dive in and, start throwing some questions at you that we get from the community, maybe just if you could take us through a bit of your background, how you got into the space, your passion.
Absolutely. So born and raised in Austin, Texas, which is a great city. If you've never been over to the States, Austin is a really funky place, and certainly liberal, left liberal, not right liberal, Australia liberal. Yeah, look, I've always wanted to be a GP from when I was a kid. I had a very influential GP myself, and also a couple of my best friends' fathers were doctors. So it's always been something that I wanted to do. Tried to get into medical school a few times and had good entrance exams, but not great college grades. So a little bit of a delay there. I finally just said, hey, I'm going to get this done. I went to a Caribbean medical school on an island called Dominica, which is in the westward, Leeward Islands. And it's between Martinique and Guadeloupe. Great place to go to medical school. I was in the water and hiking more than I was in class, to be honest. But I did.
Is that a photo of the island behind you, by the way? I'm just.
No, that's Rottnest, which is.
Oh, that's Rottnest.
So now I've got plenty of good pictures to show you of Dominica at some point. But and then did clinical rotations in the States and really set up all my rotations myself. One of which was in Wyoming, and ended up doing residency in cowboy country north of Colorado. And so at the time of residency, stuff was kicking off as far as medicinal cannabis. So then I had plenty of patients who basically went interstate, got a medicinal cannabis card, and kind of had my eye on it since then. And so in 2016, when it kicked off here in Australia, certainly was paying attention, but didn't get into it really until later on. I started prescribing with a local pain specialist, and then the legislation went through for GPs to do it by themselves. So that's when I really started doing it almost exclusively. I still have GP patients, but my GP spots are less and less every week, just because it's gaining favor and grassroots, and the good data that we're getting is getting out there. So that's when I started, seeing the anecdotal evidence and the motivation to really help people through this new non-conventional avenue.
Nice.
Amazing.
Yeah. So, and then I guess coming to Australia and seeing this industry start from a position quite a bit further back than,
Yeah.
where you'd come from in North America. Um, you know, what's your kind of sense of how it's been done here? Do you feel like
I think
it's
it's way better, to be honest.
okay?
Yes, it's more regulated, and access is more difficult, but I think that's a very good thing because of how the TGA is getting that data, and we're all compiling it instead of giving our patients a medicinal cannabis card, and then that's the extent of our influence.
Yeah.
There was no management for those patients. They went to the dispensaries and got whatever they wanted, and therefore, that ability to gather the data to really back it as a conventional therapy or a first line therapy like the TGA is doing, we didn't have in the States. So I think it's a better system here.
Yeah. Nice.
Very
Uh,
interesting.
And what are since you have, gone out and, done the specialist cannabis clinic, what are a lot of the people who come to see you, what are they coming to you for?
Oh, well, I think same as most folks who are prescribing cannabis around the nation, you know, for the most part, it's chronic pain, intractable, chronic pain, whether that be fibromyalgia, rheumatoid conditions, chronic osteoarthritis, but it's also cancer pain and treating, patients for symptoms due to that cancer treatment. You've got your psychological or mental health issues, anxiety, PTSD, insomnia. So those are really common in my clinics too. So not really anything different, but for the most part, it's chronic pain patients over 60, conservative who've run out of options.
Hmm.
Are you finding that it's in your experience, it's an effective treatment?
I do, absolutely. It's allowing one medication to hit potentially multiple indications, getting rid of polypharmacy. Certainly those folks with chronic pain who are on, opiates, who are on neuropathic pain medications like Lyrica, and benzodiazepines for muscular spasms and, insomnia because of their pain. So it has been a very effective management strategy for those people. No, it doesn't work for everybody. I would say probably 20% drop off due to, cost, due to ineffectiveness, or other reasons. But for those 75% that continue on it, they're super happy. They're sleeping like they've never slept before. They're able to get done those things during the day that they hadn't been able to do. And that quality of life increase is priceless.
No, totally.
Yeah.
I hadn't actually considered the polypharmacy angle. And I know that, I mean, you mentioned for some of that 25% of patients that come to see you, cost is prohibitive. I know that there are private health funds that are trying to
There
assist
are
them,
now. Yep.
and that's all really good stuff. But I can sort of start to appreciate that, yeah, for the person who has, the benzos for their anxiety, the Lyrica for their neuropathic pain, strong opioids. I know some of these are, subsidized medicines in Australia, but the costs really would add up. And if you're able to just take a single product, right, that really is a game changer.
It is. And they like it. They're proud of themselves when they come off of those medications because, gosh, man, that's taking multiple medications that aren't working, it begins to weigh on you, yeah, look, we're helping that in multiple avenues.
And I've heard, I mean, I know there's been a lot of discussion around the dependency issues that come from medicines. And I'm going to ask you about, chronic pain, which has been in the news of late. And then after that, I want to, quiz you about just tolerances to medical cannabis. So sorry, I'm just laying that out while I'm thinking of it. But yeah, in the news, I read yesterday that the head of the Australian New Zealand pain medicine had sort of come out and said, look, there's just not enough known about medical cannabis. The clinical research is just not there. And as a result of that, our organization is telling, pain medicine clinicians that they shouldn't actually be prescribing medicinal cannabis really under any circumstances, except if patients are involved in a clinical trial. What are your thoughts on that?
Oh man, so many, it's hard to even get them out, to be honest. Yeah, look, my first reaction was like, what the heck's he talking about? I think it's really dangerous what he did, because, and it puts the patient back into a place where they're hiding what they're doing, or feeling ashamed, or feeling like, oh, maybe I can't do this. Maybe this guy knows what he's talking about. Well, in fact, I don't think he does. And I'll say that outright. I think if he has a more patient-focused perspective, then he'd be thinking about it differently. Okay, it's about our patients, number one, first and foremost. And I say that all the time. It's so important to listen. And those medications that he's backing are not very good. In fact, there's data that shows that Lyrica has no real efficacy on neuropathic pain, yet they're still prescribing it. They're still prescribing opiates that have toxicity and lethal doses, which cannabis doesn't. The side effects for those are pretty bad. So when you look at it in a simple manner of comparing it from one to the other and saying that medicinal cannabis has no role, he is dead wrong.
Yeah. So, you're basically saying that, it has a role, whether he's sort of accepting of that fact or not. He's saying that its role should be confined to the research lab. And I think it was Professor Ian McGregor from the Lambert Initiative who came out and just said, look, that might well be his view, but the thing he has to contend with is that, why would all of these patients continue to seek legal access to the products that they're already, these medicinal cannabis products? That demand surely can't be explained.
Very good point.
There's no efficacy. And I guess, so it's almost ignoring a weight of anecdotal evidence. And I think there was also another point from Peter Crock, the head of the industry body, about how this type of commentary just only further pushes people towards black market to potentially serve their needs. But if their pain doctor is saying to them, look, I would like to prescribe this to you, but I'm not supposed to, so I'm not going to. They then have to get it from the black market.
So he's not poo-pooing it, but he's pushing them into the green market, which it can be dangerous. We don't know what's in those plants, pesticides. Actually the profiles, are they what's in them actually what they say is in them? So yeah, very, very good point he makes.
It's not only why so many people are still having this great demand for it, but why are people paying the exorbitant fees that cannabis comes with as well if it doesn't work? So why are people spending hundreds of dollars a month, sometimes a week, depending on what products they're on or how much they require?
Yeah, compared to an opioid, which would be subsidized by the PBS and would be
$20 or whatever.
But they pay $400 a consult for a pain specialist.
Yeah.
Like, what are they talking about?
Yeah.
Like, you're looking at like every single month, the SASB approval rate goes up by 1,000 patients. We've got now 90,000 medicinal cannabis patients, something like that.
Yeah.
That right there shows that it works. It's working for people. They're not going to pay for it unless it works.
Yeah. Well, what's your view then? As a doctor, when you have someone that presents with chronic pain, I know that part of where medicinal cannabis is at the moment is that it's not intended to be a first line therapy. But, are you pretty cautious toward opioids and prescribing patients opioids?
Always. Yes, always. I think very early in my training, I had some experiences which were eye-opening, and got to see really that the negative side of opiates.
Yeah.
So I've been cautious ever since. And yes, there is a role for opiates, but sure, but it's not a reflex prescription for me.
Yeah. I was telling Mitch, I had some surgery last year, late last year, and just some shoulder surgery. And it was the anesthetist actually that said to me, we're going to put you on some OxyContin or whatever for, up to 2 weeks post surgery. We'll give you a little take home, little bag from the hospital with your opioids.
Yeah.
And he said to me, more than 10 days on this stuff, and your body's opioid receptors begin to form a dependency on these products. And I just found that quite eye-opening, because nowhere on the pamphlet from the drug company or any of the information did it say anything about that.
No, but you look at how, at the lethal toxicity dosing for heroin, and how dependent heroin is. And look, that's basically what it is. It's pill form of heroin. And yeah, nobody's giving you those black box warnings or advice, which is scary.
And yet, people taking CBD for their pain for 10 days is, there's no reported dependency that that's coming out. So anyway,
It's night and day, buddy. It's on opposite ends of the spectrum as far as risk, definitely.
Well, I suppose it's all part of the journey of medicinal cannabis. There's going to be different commentary from different, subspecialties in
Sure.
medicine. And, but no, I just wanted to get your thoughts on that. Now, in relation to medicinal cannabis, I wanted to ask about, it probably does follow on from opioids. You hear about people who have been managing their pain with those kinds of strong medications, how their tolerance increases because their body forms the dependency.
Mm-hmm.
Do you find that with medicinal cannabis, the dosing stays relatively flatline because there's no propensity for dependency, or how does that work?
Well, I think for the most part, people stick with a certain ratio of whatever medicinal cannabis product we prescribe. There is some that do note tolerance, and those, I think that comes with the higher amounts of THC. It certainly has been with my folks. So there are some percentages of patients whose doses do escalate a little bit. And so then we talk to them about tolerance breaks, and give them helpful education and information on how to do that. And that tolerance break is very successful to reintroduce at lower doses, and then their symptoms are controlled. So there is some down regulation of receptors in the brain to cannabinoids. And I don't know the specific statistics on that, but I think for the most part, people's doses remain stable, but there are some that get tolerance.
Okay. So how does a tolerance break generally work? Like, what's a typical tolerance break kind of?
Yeah, look, I mean, I think very simply, it's abstinence from the product, and for a certain amount of time, anywhere from 2 to 6 days, something like that. It just depends on how many milligrams of THC they're either ingesting or vaporizing or using in a day. And then once, I counsel them on doing those other maintenance things that keep them, their body in good homeostasis, like meditation, exercise, good diet, hydration, sleep, and really appreciating their indication or their symptoms, as well as appreciating their medication, and having a really respectful relationship with that, and really kind of talking to them about that during that time, and then reintroducing cannabis, however long they have their abstinence. At the end of that, introducing it at, half doses, even less, and then slowly increasing, and then paying attention to their symptoms. And once their symptoms are controlled, then they continue that dosage. And it's usually a lot less than when they started their tolerance break.
I'm just curious, do you ever kind of switch up in that tolerance break if the pain is great, say in a specific patient? Do you ever switch that up with more traditional medicine, say a Lyrica type thing or an OxyContin type medicine?
I don't, because I just don't want to introduce them and then have trouble getting them off of them again. Or, but for the most part, everybody that does the tolerance break makes it through the break.
Yeah.
And with reintroduction, they're so much happier because they're using a lot less, and that means a lot less money, and a lot less consultations with myself. So
yeah,
that's typically how I do it, bro.
So interestingly, like I hear we always talk, or there seems to be a lot of talk about kind of traditional medicines like OxyContins, for example, versus cannabis. And it seems to be this like kind of polarized scenario where it's like you're on one team sort of thing. Is there any kind of room for them to work together or not really? Or is there different drugs that work better together, like SSRIs or things like that you would suggest?
I definitely think they can work together. Absolutely. And those that, I'd have to look up some of the specific studies for you, and I'm happy to do that. But there are some that show, a lot of them, in fact, show that your opiate doses are greatly reduced in folks that have introduced cannabis as a therapy or are doing it themselves. So yeah, look, I think there's definitely room to take both. And there's plenty of anecdotal evidence, certainly with my patients. I've got many that have come completely off of their opiates. And this isn't, Endone 5 milligrams. This is OxyContin 40s multiple times a day, along with Lyrica, along with benzodiazepines, and slowly titrating them off each one at a time. And they stay off of them. So yeah, look, I don't know how many pain clinics are doing that, or if there are. I don't think there are many that are doing it in WA. Have you guys heard of any?
I don't know about WA, but one of the other doctors that we've spoken to through our AltMed podcast series is Dr. David Feng, and he spoke actually a little bit about this. And
Yep.
I guess the sensitivities around, it's all well and good, and the patient might be on board to really give medicinal cannabis a try, but the managing doctor kind of really needs to pay close attention to that process of weaning off at a stage by stage, because they can, the withdrawal symptoms, a whole bunch of other things that can come.
Super important. Like, yeah, that's a real thing. And anytime you're taking patients off of opiates, you do it in a very slow, controlled manner. And I usually mark out a plan, and this is not weeks, this is months, and plans on a day-to-day basis, so that people can see, that their doses are escalating, they have some are decreasing, and they have something to follow visually.
Yeah.
But yeah, I agree with them. Definitely. It's a slow process, and I do it one at a time over a long period of time.
Yeah.
Is that the same? Is that the same with other drugs they might be on? Because the polypharmacy thing is really interesting. I mean, when you think about it, somebody with maybe a neurological disorder or Parkinson's or MS, it's not just the relaxing of the muscles; it's also the pain. It's also potentially anxiety or depression that might come as a result of that condition.
Totally. Comorbidities, definitely.
Yeah. So are you finding but with the other drugs, say for anxiety or mental situations, is it the same kind of thing? You like weaning off, or can it be more of a cold turkey scenario?
Well, your SSRIs or first line therapies for any of your mental health issues like depression, anxiety. Those you can titrate off of, pretty easily over 2 to 3 weeks. And I do have a titration schedule for that as well. And there's a few, kind of, niblets that I've been shown through just interactions with psychiatrists on how to do that with different medications. The SNRIs tend to be a bit more difficult, just with withdrawal, the brain zaps and dizziness. But again, I would do that slowly over, weeks, rather than cold turkey, because that can be very unpleasant, some of those withdrawal side effects. So there is with the mental health medications, there are some withdrawal that cannabis can really help. And I've seen it with my patients.
Amazing. Got definitely a more fun question here.
Yeah.
Top 3 questions you get asked from patients.
Am I going to get stoned? How how expensive is it? Certainly is one of those top 3. And can I drive with it?
Mm.
Yeah.
The driving issue is a real one and a frustrating one. Because we're given access to this medicine, but on the other hand, we're dinged for it. So there's a real it's just a real disconnect there. I think the Drive Change campaign will result in some standardization of THC levels for driving. Thank goodness Tom Arkell and the gang at Lambert came out with that stuff, which CBD has no effect on driving. THC does for a certain amount of time. But, even patients that, stop their or skip their dose in the morning can still get dinged with a swab on the roadside that day. So it's not fair. That's the third question I get asked a lot.
I've heard.
Yeah. Oh, you go, Mitch.
That's right. I was just going to say, I've heard that they're just on the grapevine, don't quote me on this, but potentially up to 0.8 milligrams of THC. Some people have said that it doesn't really show up.
Yeah.
Have you heard that?
I've heard that too. I don't have the data or specifics on exactly the milligrams, but I think it's pretty close to 1 milligram per mil of, your oils and things. I think it's close to a 1.
How would you feel as a doctor, say if you had something that was under that, would you feel comfortable, like how does that kind of feel for you with your
it's uncomfortable because I don't know for sure, it's that gray area, and I don't want to be responsible for patients losing their license. So, again, I talk to them about not driving, have someone drive them, skipping your dose to drive, or taking your medicine if it's got THC in it till after they get done driving or back home, or split dosing using a product with low THC, like less than 1 or 1%, and using that during the day while they're out and about, and then using a higher THC at nighttime. So I'm not comfortable yet prescribing a certain amount of THC until we get some standardization or some data, really.
Yeah. And are there certain types of products you tend to gravitate more towards, or?
I think all of us really use oils mainly. I think just because of our indications and that onset, or rather duration of action, like a slow release, tablet. Patients benefit most from that. So I think I prescribe mostly oil, but have certainly started prescribing more dried flower and other products, just as I've been more comfortable prescribing them and seeing results. And so, that's what I got.
Yeah, nice. I just had a question about, we were talking before about what's in the news, and because this is an alternative medicine podcast, I mean, I think it was earlier in February, the TGA handed down an interim decision that basically said, we're not interested in down scheduling psilocybin, otherwise, magic mushrooms, or MDMA, active ingredient in ecstasy, for any therapeutic use. So they're still going to remain Schedule 9 prohibited substances.
Mm-hmm.
And lining up to applaud that interim decision was the Royal Australian New Zealand College of Psychiatrists.
Yes.
So I guess my question is just around the way that, leading industry, I guess, how would you describe these professional associations of, certain clinical specialties, seem to be really restrained in their support, to put it diplomatically, towards these alternative medicines. I know you probably won't have much if at all, clinical experience dealing with MDMA or psilocybin. But what are your thoughts on those emerging medicines? And
I think it's awesome. I think it's awesome. And we've got to have these talks, these uncomfortable, talks about it. We've got to push the space forward with other therapies, and I'm all for it, absolutely. And there is data, although not the big data that randomized placebo controlled stuff that we all like to see for our new therapies. But I think it opens the door. It sets up the stage for, very similarly, for use, an unapproved medication, but we're able to access it in the right way for the right indication. I applaud it. I think it's great, and I intend to do it myself. Absolutely.
Really?
I intend to prescribe. Absolutely. I think that will be my next potential, therapy that I myself, educate myself on and get comfortable with, because I think that's important to give our patients that other option. So I'm listening, and I'm going to be reading a lot about it and watching that space for sure over the next couple of years.
Well, there's a big conference in Melbourne.
I was signed up for the Mind Medicine conference in November, but the COVID thing happened. So my wife and I were both going to go, because my wife is in mental health. She's a clinician as well. So we were both really, really interested to hear what they had to say about it. So I'm coming, boys.
Yes, that is awesome news, because I'm planning to go myself. I think it's going to be wonderful. We've got the guy who's, I think his name's Rick Doblin or something. He's, really championed the MAPS studies that are occurring internationally and looking into all of this.
How cool. Cool. That is amazing.
It's awesome. And, even hearing about, just there's so much coming out. I learned today that a lot of the research in that space is coming, from psilocybin research more so than LSD. And from a practical level, that's partially because LSD trips typically go twice as long as psilocybin. So, you have to pay twice as much for your clinical research stuff and, all that stuff. But it's really, it's emerging and it's helping people. I know US veterans are getting heaps of help with their PTSD. But I don't know.
And ketamine too.
Yeah, actually, when I was in hospital for the surgery, I was in a ward with a guy who had just chronic pain in his testicular region for about 7 years, and he was coming in for his very first ketamine infusion at the hospital, and I got to actually be there.
What? Tell me about that.
Ketamine infusion. I'm like, that's illegal. I mean, I knew people doing that back in the day, but it wasn't done in a therapeutic context. But it was, this guy got so much relief off that. So it is nice to see all these these emerging therapies being taken out of the world of prohibited and illicit substances. And
I mean, it's where cannabis was. It's where cannabis was years ago. And yeah, look, I think it's exciting, isn't it?
Yeah, absolutely. Well, we'll definitely have to catch up
at the conference, buddy.
Yeah, at the conference in November in Melbourne. But Mitch, did you have any more questions for Matty before we let him go? I'm sure we'll get him back on for another episode.
Oh man, get me on. I love it. This is great.
Amazing.
I'm just there is a nice little question which we seem to have been capping off, or we have done at least once, which is somewhat to do with the future of cannabis in Australia, at least. If you had to guess when we would go recreational at all, what would be your estimate?
I would say 5 years.
Now, would it be for cannabis altogether, or do you think CBD would go first, then THC?
Oh, definitely CBD first. I think they've kind of set that up, haven't they, with the the over-the-counter CBD rulings down scheduling. So I think CBD will definitely be first.
Yeah.
But I mean, I think it's being set up right now, legislation wise, in order to happen. And I think it's a good idea. you know, we can delve into that at some point together, maybe in a future podcast. But yeah, I think it's going to happen within 5, I would say, if not a little bit after that.
I just had an image actually of like sort of circa 2026, and you know, maybe all 3 of us are together when the announcement finally comes through that it's gone recreational, and we can you know, all have a bit of a party. Maybe
Yeah, I'm down for that.
We'll be doing it over maybe not a beer next time. Who knows?
Who knows? Who knows? We'll have to see, won't we?
Amazing.
Well, Matty, it's been an absolute pleasure having you on. I knew this was going to be a ripping episode. Lived up to my expectations.
Too fast, but God, let's do it again.
Yeah, we will. We'll schedule a sequel for sure. It's been honestly just, you know, a beacon of wisdom on all of this. It's so good to get your clinical insights, and just to talk to you again.
Yeah, boys, it's a pleasure, and I love what you're doing. Like I said, and anytime, let's do it again.
That sounds great. 100%. All right. Well, till the next time, we'll catch you later.
Sounds good, guys. Be well.
All right.
Thanks, buddy.
Bye.